Great. Good morning, everyone. Thank you very much. Thank you very much for being here. And it's a real pleasure and honor to introduce Dr. Kawai. Dr. Tatsuo Kawai, he's professor of surgery at Harvard Medical School. He's the Benedict Cosme Professor of Transplant Surgery at MGH and also the director of the Legaretta Center for Transplantation Tolerance at Harvard. Since joining MGH in 1997, he pioneered some groundbreaking work looking at developing transplantation tolerance using mixed chimerism approaches in transplantation. And those patients are some of the only patients worldwide who truly are tolerant of immunosuppression with a kidney. That work was published in the New England Journal of Medicine 2008 and 2013. More recently, he's been involved in xenotransplantation, has performed the world's first pig-to-human xenotransplant, published just this month in the New England Journal as well, and more recently, the second one, which we'll hear about shortly. So thank you very much, Tatsuo. It's a real pleasure to have you here. Thank you.
Thank you, Fadi. It's a great pleasure to be here with you today, and especially Oxford is special for me because my son, Kento Kawai, completed his DPhil here under the guidance of Dr. Issa. Thank you very much. And today I'd like to share my experience, our experience about first genetically edited porcine kidney transplant. And we also did a second transplant very recently, so we're going to include that case in my talk too. I have no disclosure. This figure showing this figure showing the number of patients on kidney wait listing and the actual number of transplant in the United States. As you can see, only less than 30% of the patients actually can get transplant. And so this huge gap is a problem. And organ shortage is now growing clinical crisis in the United States and all over the world. To solve this problem, we consider xenotransplant is a promising approach. Oh, sorry, this one. Yeah. So our transplant is not the first xenotransplant. It's concordant transplant, but Dr. Lee Mutsma did a concordant xenotransplant from chimp to human in 1964. The immunosuppressive therapy he used is very primitive, only Imuran, actinomycin C, and steroids, and local irradiation to the graft. It's very no CNI available at that time. As chimp's kidney is very small, he did a en bloc kidney transplant like we do for pediatric donors. And the 6 patients underwent this transplant. Most of them died between 11 days and 63 days, but one of them survived over 6 months. These results, actually great results, I think, with this considering only the primitive immunosuppressive medications available at that time. If we can do this kind of a concordant xenotransplant with a modern immunosuppressive medication, we should be able to achieve much better results. But why we cannot use a non-human primates? The biggest reason is a higher risk of zoonosis, because you can see we have been seeing Ebola and Marburg monkey virus outbreaks in humans, And also probably HIV is also coming from monkeys. And ethically more difficult. They are endangered species. And large-scale organ supply is difficult. Also, organ size is very small. Therefore, FDA banned the use of non-human primates for xenotransplant in 1999. Major reason is a zoonosis risk. Then why pigs? Pig has less zoonosis risk than non-human primates. Still have it, but much less risk. Ethically more acceptable, and large-scale organ supply is possible because they can grow to 100 kilograms in only 1 year, and organ size is comparable to human organs. However, if we transplant wild-type pig kidney to non-human primates, they can be rejected in 10 minutes like this. The reason is that the carbohydrate xenoantigen is expressed on the pig cells. Biggest the carbohydrate antigen was alpha-gal. The gene is GGTA1. We have natural antibody to alpha-gal. So for successful xenotransplantation, we have to get rid of alpha-gal from the pig cell surface, by deleting GGTA1 gene. But Missouri group first successfully generated a heterozygous gal knockout pig in 2002, followed by Bob Hawley and David Sachs at MGH successfully generated a homozygous gal knockout pig in 2004. As soon as these pigs became available, Kazu Yamada and David Sachs transplanted these pig kidneys into baboons. Then they overcome hyperacute rejection. So they survived, was not rejected within 10 minutes. They survived at least 20 days. Then longest survival was up to 90 days. Somehow, with this transplant, autologous thymus, so it's a pig thymus, needs to be co-transplanted with the kidneys. Without the thymus, the survival was up to 30 days, but with thymus, survival prolonged to 90 days. However, no animals achieved survival more than 90 days, which is not ready to clinical trial. Around that time, the concerns about porcine endogenous retrovirus emerged. So the Robin Weiss laboratory have shown that infection, those PERB can infect human cells. So around 2010, because preclinical study graft survival is not sufficient to go to human, also the concern of PERB has grown. The research on xenotransplant was stuck. However, game changer was Nobel Prize winning technology, CRISPR-Cas9. With this technology, we can now delete and insert genes so easily and efficiently. So using this technology, the George Church and Luhan Yang successfully inactivated the PERB and created PERB-free pigs in 2015. if you look at the xenoantigens, it's just GAL is not the only carbohydrate xenoantigens. There are the two others, major one, SDA and Neu5Gc. So those can be now deleted by CRISPR-Cas9 easily. And if you delete only GAL, we call GAL knockout GTKO. And if you delete GAL and SDA, it's called dual double knockout. And if we delete all three, it's called triple knockout. So this is showing human natural antibody binding to pig cells. The antibody binding against wild-type pig cells is this level. By deleting alpha-GAL, GTKO, this binding can be reduced this level. And if you delete GAL and SHIMA, then binding can be reduced to almost control level. Another barriers in xenotransplantation is protein incompatibility between primate and pigs, because just a small structural difference makes pig protein dysfunctional in a complement cascade and coagulation cascade or inflammatory responses. For example, this is showing the complement cascade. To inhibit those complement activation, the proteins expressed on the cell surface like CD55, CD46, and CD59 is very important. However, if this is pig cells, those pig proteins are not able to regulate those complement cascade of the primate. Therefore, those proteins needs to be replaced with the human proteins by human transgenes. So egenesis was actually founded by George Church and Lu Han-yang in Cambridge, Massachusetts. It's close to Mass General, 10 minutes away from our hospital, and we started a collaboration. Then egenesis basically made a triple knockout pig with PARP inactivation and different variations of human transgenes. We transplanted organs from these pigs at Mass General, and the results of kidney is best, followed by heart. And fortunately, so far, the results of the liver and the lung is only a matter of days, and it's still far from the clinical application. This is an immunosuppressive regimen used in non-human primates. We used thymoglobulin and rituximab induction to delete on T-cell B cells. Then we did a kidney xenotransplant from these pigs, and followed by anti-CD154 and Ceresept. We also used tacrolimus and steroids, conventional immunosuppression for 60 days, but stopped it on day 60. And after day 60, only anti-CD154 and Ceresept, which is not really immunosuppression. It's not so hard, heavy one, not heavy one. So we believe triple knockout is best for humans because natural antibodies binding to triple knockout pig cells is the lowest. However, the requirement of those human transgenes is controversial, especially in triple knockout pig cells. Therefore, we started, we tested various kind of combinations of human transgenes in monkey transplant. We started by triple knockout with no human transgenes. They consistently lost xenograft very quickly after transplant, mainly due to acute tubular injury. But by adding those CD47 HLA-E, which is to inhibit macrophage activation and NK cell activation, as well as complement regulatory genes like CD46, CD55, CD59, the xenograft survival was significantly prolonged. But by adding coagulation regulatory genes like thrombomodulin or EPCR, it didn't further prolong the xenograft survival. However, finally, by adding anti-inflammatory proteins like H2 and HO1, 50% of the recipients survived over 1 year, with the longest survival exceeded 2 years. But this was actually published, part of the results was published in Nature in 2023. But we became confident that we may be able to go to humans. But I was still reluctant to talk to my patient about pig options. But it was changed after joining this conference held by National Kidney Foundation to hear the patient voice. At the conference, patient and patient family strongly advocate the xenotransplant, and they ask us to strongly to go clinical trial. And one of the online survey was asking if your transplant kidney is failing, do you want to have pig kidney transplant? So amazingly, over 40% of the patients is very likely, answered very likely. So encouraged by those patient voice, we started to look for the proper candidate for xenotransplant. So Mr. Richard Raymond, I have known him very long time since he started dialysis in 2011. He's a 62-year-old male with end-stage renal disease due to diabetes. And he's on hemodialysis since 2011. But from the beginning, he had suffered from the multiple difficulty to create a vascular access. I think I did almost all of his vascular access surgery, but it's more than 10 surgeries. But the reason is that he occluded both central veins and upper extremity options is gone. So eventually we had to create vascular access in his thigh region. But we did a deceased donor kidney transplant on 2018, but it's only functioned for years. He lost graft because of recurrence of diabetes plus BK virus infection. He resumed the hemodialysis in 2022. Then he started to have a problem about the vascular access again. So eventually, only access available was left femoral vein, and we placed the HD catheter in the femoral vein, but it's often clotted, and he had to come to ED almost every week. Then we approached him about discussed, because also he didn't have a transplant option because he had to wait another 6 or 7 years for next transplant. So therefore we approached him about discussed about the xenotransplant option, and he accepted to go forward. So we got the FDA IRB approval. IND for single patient expanded access authorization using pig kidney from eGenesis, triple knockout, power inactivation, and 7 human transgenes. And also using anti-CD154. Tegoprubart is been on phase 2 clinical trial for kidney transplant right now. But they agreed to provide CD154. So pig was transported by ground from a Wisconsin farm to Massachusetts. We didn't bring the pig to our hospital. We used GLP certified contract research facilities about 1 hour from a hospital. And we procured 2 kidneys and brought them back to MGH for transplant. So kidney was left kidney, 155 gram from a 75 kilogram pig. The patient was about 100 kilograms, so this kidney was a bit smaller side. Cold static storage and cold ischemic time was 4 hours, 38 minutes, and warm ischemic time was 36 minutes. It was a bit difficult surgery because he had used the left side already, and we had to go to left side. But his severe calcification of the iliac artery make transplant a bit difficult to find out the soft spot to do anastomosis. But the kidney after perfusion, kidney pinked up very quickly. It's immediately pinked up. Usually in non-human primates, it takes like 5 minutes from a bit dusky color to get to become a good perfusion. It takes 5 minutes, but this kidney immediately pinked up and started to make urine within 10 minutes. So this is a function. We usually don't get excited so much about kidney transplant, but this is a moment we saw our first urine out from the pig kidney. That's why everyone got excited. So this is a immunosuppressive protocol used in this patient. It's almost like a monkey protocol, but after ATG and anti-CD20 monoclonal antibody induction, we used the triple immunosuppressive medication plus tegoprubart. Different from monkeys, we started tego from day -3 to make this antibodies level therapeutic by day 0. And also we have seen thrombotic microangiopathy, TMA, in monkeys often. Therefore, we added labedurizumab anti-C5 antibody. So this is a post-transplant course of this patient, and this thick blue line indicates creatinine level. Yeah, and red line indicates the anti-CD154 trough level, and green line indicates tacrolimus level. So we started tegoprubart day -3. Then the antibody level became therapeutic, over-therapeutic actually, 1,000. The therapeutic level is supposed to be 750, so it's too much, but day 0. then we started to have a concern because this level is too high, and intentionally we reduced the tacrolimus dose and during the first week. And this creatinine nicely came down to 2.2 by day 6. But the patient started to have fever, and urine output became sluggish on day 7. So we suspected some rejections coming up, so used anti-IL-6 antibody and steroid pulse preemptively and did a biopsy. Then biopsy showed cellular rejection with a prominent CD3 infiltration, but no C4D, no evidence of antibody-mediated rejection, and no TMA. Therefore, we treated this rejection with ATG and steroid pulse. But also, we saw C3 positive staining. Therefore, we added a C3 inhibitor, pegcetacoplan. And after treatment, the CD3 is gone, T cell is gone, and C4D remains negative, and no TMA, no antibody-mediated rejection. So this day 34 follow-up biopsy showed resolved rejection. So he discharged on day 18, and he is a true hero. That he mentioned that I consented this transplant not only for me, but for the medical progress that may help millions of patients like me. So hemodialysis line was removed, and electrolytes remained stable, and good urine output, and discharged creatinine was 1.7. So after discharge, we raised tacrolimus level to therapeutic level between 8 and around 8, between 6 and 8, and adjusted the tegoprubart level to around 500. Creatinine remained stable, but unfortunately, unexpectedly, he suffered cardiac death on day 52 at home. The autopsy showed severely hypertrophic heart with a diffuse multifocal myocardial fibrosis. You can see in the blue. But there is no evidence of acute myocardial infarction or pulmonary embolism. So we concluded that cause of his death is probably lethal arrhythmia in the context of severe ischemic heart disease. But the autopsy kidney didn't show any rejection, no cellular rejection, no AMR, no TMA. So this case was just published this month in New England Journal of Medicine, so you can read the detail of this case. So we did another transplant, second transplant on January 25 this year. This time left kidney, 170 gram from 70 kilogram donor. Somehow, last time it was 75 kilogram donor, but the weight of the kidney was less than these kidneys. But recipient was a 90 kilogram patient, 66-year-old patient with diabetes. Uncorded ischemic time 2 hours 39 minutes, and the operation time is much shorter, 2 hours. because he doesn't have so much vasculopathy. And kidney picked up immediately and started to make urine also within 10 minutes. So the more likely transplanting like a living donor kidney than deceased donor kidney. So he's this is a creatinine, and orange bar is indicated GFR. So after transplant, creatinine nicely came down to 1.2 by day 6. Then the patient was discharged on day 7. But the creatinine bumped up on day 14 from 1.2 to 2.2. We did a biopsy, and biopsy showed dense cellular infiltration, and this is mainly T cell and macrophages. And if you look at arteries, there is arteritis. So therefore, this was diagnosed as a T cell mediated rejection, grade 3. But there is no evidence of AMR or no evidence of TMA. So it's easier for us to treat the cellular rejection because we have lots of treatment against the cellular rejection. So we treated with ATG and steroid pulse, and then creatinine started to become normal, and the GFR came back up, and last creatinine is 0.9 and GFR 92. We're supposed to be able to do 2 more transplants this year, and hopefully he continue to do well. And we are looking for next patient right now. So this is Mr. Andrews, second patient, at the picture taken at day 7. This is Dr. Riera, he's nephrologist. He did a great job on getting approval from FDA. And lots of people involved in this patient care. As I told you that Dr. Riera and Kiri Kurisari especially worked hard. And people from eGenesis. Thank you very much.